Welcome everyone to today's webinar, Enhancing Care Coordination Across the Continuum, a guidebook to reducing readmissions, sponsored by Point Click Care. I'm Brian Zimmerman, Senior Director of Content with Becker's Healthcare. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation, and we'll have time at the end for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. We will also have 2 poll questions during the presentation. To participate, please click on your preferred response when the poll appears on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. And at this time, I'm pleased to turn the floor over to Nikki Sterrett, Director of Value-Based Care at Collective Medical, a Point Click Care company, to begin the presentation. Nikki, take it away.
Thank you, Brian, and thank you, Becker's Healthcare, for this exciting opportunity to discuss readmissions, which is such an important topic. I'm Nikki Sterrett, and I'm proud to represent Collective Medical, a Point Click Care company. In my role with Collective as Director of Value-Based Care, I'm focused on helping our clients leverage Collective's care coordination platform to improve the quality of care and reduce costs. Prior to joining Collective, I led a range of population health initiatives and programs for ACOs in Massachusetts, spanning areas such as care management, post-acute care, and IT. Joining me today for our presentation are 2 physician experts who I happen to know and have had the pleasure of working with in the past. They both have a lot of passion for healthcare improvement and significant experience with tackling readmissions. We're so grateful that they've offered to share their expertise with us today. So first, I'll introduce Dr. Amy Beltwell. She's the founder of Collaborative Healthcare Strategies and the developer of the STAR, Aspire, and MVP methods. Dr. Beltwell works at the intersection of healthcare delivery improvement, public policy, and excellence in clinical care to design and lead large-scale delivery system transformation initiatives at the regional, state, and national levels. Dr. Beltwell also practices hospital medicine. We also have joining us today Dr. Enrique Anguidanos. Dr. Anguidanos has been practicing clinical emergency medicine in the Puget Sound region for 20 years. He's been implementing community-based solutions for complex care patients for the last 15 years, currently as CEO of Community-Based Coordination Solutions, or CBCS. CBCS provides value-based solutions for organizations struggling with complex care patient engagement and utilization. Dr. Beltwell and Dr. Anguidanos, welcome and thank you again.
Thanks, Nikki.
And Dr. Anguidanos is having a technical issue, but we are expecting him to join shortly. So now I'll just briefly review our agenda. We've already introduced our wonderful speakers. Next, we'll be spending a few minutes just setting the stage and understanding why readmissions are such a hot topic. Then the centerpiece of our presentation will be a discussion with Dr. Beltwell and Dr. Anguidanos that should provide our audience with actionable strategies and insights for tackling readmissions. And then we'll wrap up with a summary, some takeaways, and the audience Q&A. So diving into the impact of readmissions, most people are probably aware that readmissions continue to be one of healthcare's biggest problems, and it's not going away. I talk to ACOs and health systems across the country every day, and readmissions continues to come up. So one of the reasons for this is because healthcare is growing increasingly complex. Providers are taking on more patients, there's more specialization, more documentation, and more systems and tools being used that don't talk to each other. In fact, the average healthcare system has 18 different EHRs that are used across their providers. So this makes data integration and accessing data very difficult and cumbersome and creates challenges for coordinating care, leading to readmission. And readmission costs are not insignificant. We know that across the U.S., the costs associated with readmissions and fragmented care adds up to over $26 billion annually. And digging a bit deeper, we know that many readmissions happen because patients they're not staying in one place, right? They're moving between care settings, and care transitions are not always ideal. Medicare patients that are discharged to a SNF have a 25% likelihood of being readmitted within 30 days. And a third of all SNF readmissions happen in the first 3 days or first 72 hours. Over half of those are due to medication errors and other similar issues with data flowing between the acute and post-acute settings. So at this point, we have our first audience poll, and we'd love to hear from our audience on your challenges with reducing readmissions. So select from the poll on your screen, what are your biggest pain points with reducing readmissions? Please select all of the choices that apply. We'll give it just a few more seconds for the results to come in. Okay, and it looks like most of you are struggling with lack of visibility into post-acute care and coordination with ED providers. So in the next section, I'm sure that our physician experts will speak to these areas and share some valuable insights on how to address these pain points, as well as some of the other pain points that you see here, such as identifying high-risk patients, workflow inefficiencies, monitoring readmissions, and tackling behavioral health and substance use disorder. Right, let's dive into the main event. Dr. Beltwell and do we have Dr. Anguidanos?
Yes, Nikki, I'm here.
Great. I'm so excited to be sitting down with both of you. We are going to pick your brain on 5 different themes, starting with success stories. So first, you both have significant experience working with organizations at various levels, individual level, regional, state, and even the national level to reduce readmissions. What are some examples of organizations that have found success here, and what were their strategies? So Dr. Beltwell, let's start with you.
Okay, great. Well, Nikki, the good news is that at the state and national level, there are too many stories of success to even count. And that's really the message I want to send here is this work hard? Yes. But is there a path forward to get measurable success? Absolutely there is. And so, just to start and paint a picture, the stories of success that I've been fortunate to be a part of or help lead along the way over the past decade really have emerged from the work of the Aspire Guide. This is called Designing and Delivering Whole Person Transitional Care. It's a guidebook that I wrote for the Agency for Healthcare Research and Quality over a 5-year period of field work and tooling and retooling the methodology. So the Aspire Guide has been shared at the state and national level and been used by hundreds and thousands actually of teams across the United States at this point. And so the stories of success range from small rural hospitals where, one champion wears multiple hats and embraces the methods and practices and concepts of readmission reduction and good cross-continuum partnerships through to community hospitals and safety net hospitals. So, so without, regaling everybody with a bunch of stories of success, I just really want to be the messenger of large-scale, broad success in reducing readmissions. A few statewide data points would be would include the statewide success that we saw in Maryland over the past 5 years in one of their 5-year waiver demonstration programs. When I first came to Maryland, Maryland had ranked number 47 out of 51 states and DC for the worst readmission rates in the country. And over a 5-year period, by using data and driving performance and fostering cross-continuum collaboration, the entire state of Maryland, all 46 hospitals, all hospitals in Maryland, collectively went from number 47 worst in the country to meeting and beating the national average for Medicare readmission rates. Just an incredible story of success. Now, did the largest academic medical centers use some, did their programs look a little different from the community hospitals, from the rural hospitals? Of course they did. But what a robust testimony to the power of our abilities to reduce readmissions by seeing an entire state go from one of the worst to then meeting or beating the national average in aggregate over a 5-year period. And briefly, the same thing happened in New York with the 5-year Medicaid district waiver that was just ended. Again, an incredible reduction in potentially preventable readmissions and potentially preventable emergency room visits, which is how they were measuring it, a statewide success for Medicaid overall. So the stories of success differ in localities, but there's just a lot to build on, and I'll pause there and turn it to Enrique.
Yeah, I'd have to agree with Amy. The stories are broad, and you can see them across the country in pocket states or communities. I do think there are some common strategies that we see in the successful regions. One of them is bringing a common community dialogue. And one of the ways we do that is through creating a community type of multidisciplinary team where we're not just having the provider voice from the hospital, but we're having outpatient providers and law enforcement and EMS and the behavioral health centers and the jails and all of the touch points where our complex readmissions often go. Finding a way to share that information so we're not just looking at our unique perspective, but at the perspective of all of the touch points. And that's where I think the tools like the CRISP tool that Amy uses over in Maryland or other state HIE tools can be so valuable. The point-click care collective medical tools are they're game breakers as far as this goes. And then I think probably the biggest single issue is we really have to get the patient perspective. We need to have that direct patient engagement and find out from them where we're missing as a medical industry. Why do they keep on showing back up in my ED and or in the hospitals? Because they're only doing that because something is failing for them out in the community. As far as specific programs, I can tell you a number of examples we've been involved with. Next month, we'll be presenting the HUMS, the high utilizers of Matsu story from Alaska that we reduced readmissions by over 50% within the first year. But again, it's using those 3 tools as a strategy: the common community dialogue, the shared information platform, and then really getting patients involved in the work. So let me pause there.
Yeah. Couldn't agree with you more, Enrique.
Those are some great stories and some impressive results that you shared from many different pockets and areas of the country. So moving on to our next pocket, our next theme here, we'll start to peel back the layers on what specifically health systems and ACOs and others should do to try to reduce readmissions. So I know from working with you, Dr. Beltwell, in the past, that you have a major focus in your tools and your strategies on engaging the ED. And Dr. Inguadanos, you mentioned this just now. So why is it so important to engage the ED when you're trying to reduce readmissions? And what are the most common challenges that you see here?
Yeah, that's as an ER doc, as an ED doc, I think this is part and parcel. You know, I think what we forget is the emergency departments are capture opportunities for us. We can meet patients. First of all, we can meet patients we can't find elsewhere, and so to get the staff involved and hear their stories and find some type of mechanism where we can find out in real time when patients are showing up, that is so key. Stabilizing, you know, EDs are great at stabilizing crisis events, but what we also forget is it's an opportunity to learn in real time why the patient showed up. And it might, you know, it might be the critical issue that they're showing up, but there's a lot of underlying work that's going on, and we really undervalue, I think, sometimes the ED staff input on how to prioritize patients. As an example, let's say I have a homeless renal patient with cellulitis come into the emergency department. As an ER doc, we might be able to recognize that their renal status is stable and they can be discharged home from that perspective. But if they've got a corresponding cellulitis and they're homeless, and we don't have a mechanism in the community to understand how we can address those other two issues, we're probably going to admit them. So if I go back to that issue of having a community-based approach, if we have dialogues across the community of care and some type of platform, some type of HIE, where we can get information from other sources beyond our hospital, we can make it a lot easier for the emergency department to make a decision to discharge, where otherwise we would be stuck having to admit them. Amy, any thoughts beyond that?
That's right. I agree with everything. And, you know, the way I say it is one of the mistakes, I know we'll get to this in a second, but one of the conceptual mistakes I hear people make, and listeners, I challenge you if you're in this zone, is thinking that what we're trying to do is improve care transitions. Now, that's provocative. What we're trying to do is reduce readmissions. If you reframe as the opportunity is, or the goal is to reduce readmissions, then the emergency room, the point at which the patient comes back, is an intervention site for all of the reasons that Enrique just articulated. It is real time, person in context. Why did you just come back? Did your doctor's office send you in? Did the dialysis center send you in? Did your daughter-in-law from Florida call 911 for you because she's not there? Why? Why did you just come? That opens up the entire vision that Enrique just articulated, which is you may have not come for a medical emergency. Yea, in fact, most times you didn't, right? And same thing with SNF transfers. You know, why did the SNF send you in? And so it's an opportunity to have real-time visibility that this is a person who just left within 30 days and here they are back. Now we want to dig into why exactly did you come, and we have and of course we want the quick information around what do you have access to and available to, so can we safely and appropriately discharge you, stabilize you, and discharge you from the emergency room. It is an absolute, not only a theoretical intervention site, it is proven. It's one of the major strategies that Enrique mentioned for multi-visit patients, as well as for SNF readmission reduction avoidance. And going back to the large-scale experience in Maryland, you know what Maryland did when all hospitals in Maryland were switched from a fee-for-service to a global capitated budget, where every admission now eats into their global budgets. You know what the first thing all 46 hospitals did? 24/7 crackerjack social work case management in the emergency room. to be the hub and spoke of re-triage and appropriate discharge if you are not, in fact, having an acute medical event. So it's just incredibly powerful to stand up readmission reduction teams and thinking and processes in the emergency room. It is, as Nikki said, it's part of my go-to bag of strategies.
That makes so much sense and really resonates with me and my experience leading readmission reduction efforts for an ACO and starting with focusing on the ED. I know that this can be new territory for some ACOs and provider organizations, however, or even health systems. Like, how do I even begin engaging the ED? So, and focusing on the ED. So Dr. Beltwell, you talked about putting bodies in the ED, case managers in the ED, and Enrique talked about real-time data and the platform. What are the first 1 to 2 steps that for those starting out that they should take to really hone in on the ED?
Absolutely. Such a great question, Nikki. You know, it's all about communication. So the one thing I do with my community-based work, when we come into a new community, the very first thing is I'll reach out to an ED and contact the charge nurses. I want that staff in the ED to know who we are, to know what type of services we can provide, to find out where decisions are quickly made. And typically that's going to be the charge nurse, and you'll want to meet with that cohort. And then the ER docs are another valuable cohort. But also, if we have tools such as the point-click care, the collective medical, the CRIS program that can serve as a database for care plans, for PDMP information, we need to make sure that staff has access, because that's going to be so helpful for community, for ED members to help make decisions and to understand where is there a crisis support that needs to be admitted and where is there an opportunity to perhaps do a close follow-up. So one is contacting staff, beginning dialogue. 2 is making sure the staff knows the tools and understands how to use them. Amy?
I would say, agreeing with Enrique and building on that, I would say that having the ED leadership in charge, nurse management, nurse operations, quality, and the physician leadership, having the ED interdisciplinary leadership team understand the opportunity that Enrique and I are saying in terms of the emergency room is an intervention site. It's an active site for active decision making that really aligns with what we're trying to do in emergency medicine, which is good triage. And so when I find that when we appeal to the clinicians in the emergency room and say, you know what, we can, if we create some visibility and some options for you, you part of what you do, part of what you're called to do every day is make good in, out, treat, admit, discharge decisions. And we know that we can make a few more decisions to safely and appropriately discharge. We, managerial, the platform, the information, the visibility, the processes, we're going to support you in doing that. And so appeal to their already, their sense of mission and their clinical expertise in terms of safe and appropriate triage decisions, and then empower and back that up with some tools and processes to make that easier. I'll tell you a quick example. As a hospitalist, and I call myself a readmissionary, right? All of you out there who've worked with me, you're a readmissionary. As a hospitalist and a readmissionary, I go down and evaluate my patients in the emergency room 100% of the time without fail. And I go to the emergency room and, on a night when I'm feeling particularly generous of spirit, I will, take on the call to try to safely and appropriately discharge patients from the emergency room in collaboration with my emergency medicine colleagues. And I'll tell you what, my colleagues in hospital medicine say, why would you ever do that? It is so much easier to admit them. And friends who are listening, I will tell you, I've personally done my own time studies. It takes me 4 times as long to discharge a patient from the emergency room than it does to just click through my Epic admission driver and go through the 20 steps that I have memorized and avoidably admit the patient, okay? But part of the change management is to make that time sync differential much, much smoother. We have to understand, if we're going to try to safely and appropriately discharge people from the emergency room, then we're going to have to make it easier to do that, because right now it's easier to admit. And so that's part of the work that I like to really focus on, in addition to what Enrique mentioned.
Wow, that's such a helpful example, and I know we're going to talk about tools and data in a minute and discuss that a little bit more detail. But before we do, another arena that's important to focus on in reducing readmissions is post-acute. So in your experience, similar to the ED, what should ACOs and health systems be focusing on with their post-acute partners when it comes to reducing readmissions? Where do they even start?
I'll start.
Well, I tell you,
if you don't mind.
Go ahead.
Okay. Okay, I can just heartily endorse the Interact methodology, the interventions to reduce acute care transfers. This is a method that's been around for about 8 years at this point. Really took off, 5 to 6 years ago. And if you are in post-acute care, or if you're an ACO working with post-acute providers, the Interact methodology just opens up an entire body of potential. The short description is, it is a set of tools and change in clinical status recognition tools, plus a series of evidence-based protocols to take maneuvers to make steps in the post-acute environment in collaboration with the supervising provider in order to respond to small changes in clinical status safely and appropriately and manage them on site, instead of reflexively sending someone to have those smaller issues evaluated in the emergency room. The Interact toolkit in general has reduced readmissions among post-acute patients on, an average of 35%. And so I cannot say enough, and I could go on forever, but if you haven't looked at the Interact tools or heard of Interact, interventions to reduce acute care transfers, I am just a big fan. Enrique?
Yeah, well, I go back to having to share information across the community of care, and I'm looking at some of the questions coming in, and I think some of them are very pertinent to this. It's really, we have to look at that crisis moment, that ED visit, as one piece of the puzzle. And hey, we can stabilize the crisis issue that brought the individual in there 80% of the time, but it's the corollary issues of what's underlying that led to that crisis. And that's where the dynamics in the community are so important. We need to be able to access the resources for follow-up quickly, and that involves getting community health workers involved in care and making sure they know when the patient's in there, they can help arrange close follow-up. Is that present within the community? Is there a platform in which we can share dialogue across multiple EMRs or even across multiple industries? And I do think this concept of having community-based multidisciplinary team meetings where we get to know each other, we not only share information on specific clients, but we develop those relationships across different industries that'll then allow us to understand, can we get into a follow-up resource quickly and avoid that hospital admission. And I think that's through that engagement of the post-acute providers, bringing them into that dialogue and having some type of forum in which we can meet on a regular basis and understand the work that we do.
build on that. So cross-continuum team meetings, as Enrique is describing, an essential tool. We did that in the STAR initiative. For those of you who have been working on readmissions for a decade, that's the IHI STAR initiative. One of the founding concepts was, as Enrique said, the community-based cross-continuum team meet and work together regularly. How does that help? Not only patient case conferencing, but the relationships. Quick example. So I work in a hospital where, as I said, I go to the emergency room to admit the patients. That doesn't happen everywhere. But I go down to the emergency room whenever I have a patient coming in from a skilled nursing environment. I look for, in my region, we're very lucky. We have the Interact transfer form for all ALL, 100% of patients coming in from any given SNF come with this highly structured, complete Interact transfer form. Well, to generalize, it's just a really good handoff from the SNF into the emergency room. And what does that allow me to do? The Interact form happens to have a specific line for saying, why are you, the SNF, sending the patient in? What's the change in clinical status? What were the vitals? What did you observe? And then it's signed by the person who sent the patient in. Do you know what I do? Well, first I go see the patient, and then I come out of the room and I go look for that name. And in the emergency room, before I even decide whether or not to admit, I call that person. That's what Enrique wants me to do, right? Because I have relationships, or I have the concept of a partnership with the SNFs. We're in this together. Do I know them? No, of course I don't know the actual person, but I call the person and now we're on the same team. And I'm saying, hey, this is what I see. What did you see? How is that different? Is this really different from baseline? What are you guys worried about? Because I'm really not that worried about the UTI. I think, if you can take them back, I know it's 11 o'clock. Can you take them back? And we have all of that back and forth. That never happened before the cross-continuum collaboration idea. And so, just to bring that to life, Enrique is totally right. Cross-continuum collaboration and knowing how to work with each other and how to communicate with each other is absolutely key. And in that case, I can send the patient back even if it's 11 o'clock at night, because if the SNF says, yeah, we'll take her back if you don't think she's, septic or if she doesn't need to stay there, we'll take her back. And then I go to the emergency room nurse manager and say, she can go. And they're like, what kind of miracle worker are you? And honestly, I'm not. I just talked to the SNF. so it really works.
Well, yeah, and I'll take that one step further. I mean, I think there are tools, and that's what I love about the point-click tools, is that we can have that information in the ED available to us. And so that dialogue can often happen before we even get a hospitalist engaged. And it's one, having those tools available, and two, understanding your community and the resources within the community. And as you start developing those dialogues and utilize those resources, your readmissions are going to drop. And Amy and I have seen it over again, 50% reductions within first year when you're taking those type of approaches.
That, I think, gives us a nice segue to our next theme on tools and data. So for those of you taking notes in the audience, sounds like Interact tool is one to write down. But Dr. Beltwell and Dr. Anguidanos, what other types of data specifically do organizations need to target readmissions, especially to proactively prevent readmissions and catch them before it's too late, before the patient's already being admitted through the ED?
Yeah, Nikki, I've got four simple answers to that. Answer number one is two-part, actually. A community HIE, health information exchange, such as the CRIS program that Amy mentioned in Maryland, or such as the collective medical, the point-click care tools across the state. And with that, I include the community HIEs, the Unite Us, the Aunt Berthas of the world, that have contact information for resources outside of the healthcare. That's one, HIEs and CIEs. Two, to the extent possible, shared emergency medical records across the various health systems in the community. Three, the community multidisciplinary team where we're bringing those resources together on a regular basis. And the fourth, and one that I think we all fail at dramatically in our industry, is getting the patient input. We need to sit down with the patients directly, face-to-face, and that ED visit is a perfect time to do that. If we have a tool that can ping us in real time and allow us to come into that emergency department when the patient is there in that crisis mode and find out where was the break in our healthcare system? How did they end up in the emergency department from their perspective? Amy, anything to add to that?
Oh, definitely. I'm going to go from tools to data and then back again. So data, when teams, ACOs, skilled nursing facilities or hospitals, when you're relaunching or refreshing your work on reducing readmissions, just please start with an all-cause readmission data analysis. We're going to talk about one of the mistakes, or one of the key mistakes I see is prematurely limiting your view on where readmissions are coming from because you're trying to sub-optimize on the penalty program or something like that. So with data, start with an all-cause total population readmission analysis and ask yourself not only what subgroups have the highest readmission rates, but ask yourself what subgroups have the highest actual readmissions, especially if you're an ACO. That's dollars. That's a total cost of care. So look at your data, take a broader view, look at the readmission data analysis. In the Aspire guide that I wrote, Table 1 is the analytic plan that I have used for a decade, and it has served me well. It's used by state agencies. It's been used in the CMS HIN program. It is just a really basic but tried and true and informative readmission analytic plan. So look at your data first. And then I cannot more heartily endorse Enrique's comment about root causes. And root causes, the only root cause that matters is what comes from the patient's mouth and the perspective. Absolutely. So you get to the bedside, and you ask those 5 whys. Again, in the Aspire guide, tool number 2 is the readmission interview, which basically is just a set of prompts. If you don't know what I mean by the 5 whys or what Enrique means by get the patient's perspective on the root cause, you can use tool 2 in the Aspire guide to help guide you. But once you get the hang of the conversation, it becomes very natural. One key question I ask in prompting, if you will, quote the 5 whys, is I ask the person or their caregiver, if the person can't speak for themselves, say, what was going on, right before the day or the hours before you decided you should come to the emergency room. And that's where we get the story of, well, I called my doctor, or my nurse came and she tried to call the doctor and she couldn't get the doctor. And then my daughter said, forget this, I'm taking you to the emergency room, right? A lot of times it's about the attempt to get care in the community, but the failure of the community to respond fast enough so people end up in the emergency room because they're just trying to do right by themselves. And so as Enrique said, when we get that story of why did you come, peeling it way beyond, heart failure and shortness of breath, and getting to the why did you come, why today, why now, why not yesterday, why not tomorrow, that unlocks, really everything we need to know. So do your data analysis and get to the root causes, and then other technology tools like care, visibility. Ding, ding, ding. This person has been in the hospital in the past 30 days. If you admit them today, you are personally causing a readmission, right? So I love that readmission flag. I want to know, or I want my colleagues to know, that this person is in an imminent readmission. And then the last tech tool that I like in the CMT platform is the ED Care Alert. Again, more work to do to make that highly user-friendly and highly visible, but the ED Care Alert is pushing that little bit of information to the next nameless, faceless provider in the emergency room who might just need to know something that you know that I can't find in the medical record. So lots of use for data and technology here.
I love that, and I think you both make some really good points. I've seen so many ACOs get bogged down in looking at their claims data and stratifying their population, and also looking at readmission trends and kind of stop there, right? But they have to go beyond that and also think about what's the real-time data that our care managers need on a day-to-day basis to help target readmissions. So flagging potential readmissions and digging into those 5 whys. All of that is also very important on top of the analysis. We'll move into our next theme here on market changes. So Dr. Beltwell and Dr. Anguidanos, very curious to hear your perspective on the market changes that are coming down the pike in the next year to 18 months that may impact how organizations approach reducing readmissions. So for example, any value-based payment models or delivery system reforms, maybe just overall there's going to be greater emphasis on readmissions. What's sort of on your radar, and how should we prepare?
Well, certainly the value-based payment you mentioned, Nick, is a concern. I don't know if we'll see that in the next 18 months. I saw one of the questions come in talking about what's in it for me from the hospital perspective, as far as why would they care if they're getting paid for an admission. That will change. That is changing. How quickly that will occur, you know, I'd give it a 5-year window as opposed to an 18-month window. I think the change that we've seen over the last 12 months that you know, we haven't been able to implement for a decade, but COVID helped implement is obviously telemedicine. And I think that opens up a whole new array of opportunities around readmissions and innovative use of telemedicine in the actual emergency department, engaging with patients and assuring close follow-up and making sure patients have better access to those telemedicine portals so we can do a live interaction within 12 hours, within 24 hours. If we can do that, suddenly it's a game changer for emergency department physicians. Because I tell you, as a practicing ED doc, I know that the risk for the patient is higher if I bring them in the hospital. So I want to do everything I can to not bring them in. And if I can avail myself and my community with more tools to help with that, that's going to absolutely be a game changer. And the other thing is broader community engagement, whether it's the efforts that some of our MCOs and our health insurers are doing to provide housing in communities, whether it's engaging food banks better, whether it's having needle exchanges in communities. It's looking to bring us out, us as medical providers, as medical systems, out in the community with options, and then engaging our community resources in more of the dialogue of what's going on in the emergency department. I think that's really where the next 18 to 24 months should be and will be focused. Amy?
Dr. Beltwell may have dropped.
Oh, sorry, my apologies. I was on mute still. Can you hear me, Nikki?
You're fine.
Yeah, you're coming across well.
Okay.
If I can interject this in our last minute or so of the roundtable discussion, Dr. Beltwell, okay. I'm not sure what you were planning to respond with, but I would love to hear your thoughts on how ACOs ACOs that are familiar with reducing readmissions for a Medicare population, now with Medicaid value-based care programs becoming more popular, being developed at the state level, what should they do differently to tackle readmissions in the Medicaid population than Medicare? How should they change their strategy?
Yeah. Awesome. Thanks, Nikki, for that. So very briefly, I will commend to your reading the Designing and Delivering Whole Person Transitional Care, because 5 years ago, the Agency for Healthcare Research and Quality asked my team that very actual question: how do we need to adapt or change from the Medicare best practices to better serve the Medicaid population. So the Aspire guide is exactly that whole kind of body of observation. The bottom line is that for Medicaid value-based care, we need to walk away from tools and methods around patient engagement and sites of care that are most prevalent in Medicare, right? And that's the telephone for home-based people, or, the SNF environment. Those are highly effective strategies for Medicare. So keep them for Medicare. That makes a lot of sense. For Medicaid, we need to be using texting. We need to be in person. We need to be community-based, outreach-focused, meeting people, as Enrique said, where they are, which is where sometimes? In the emergency room. When? Sometimes at 2 in the morning. So in order to do Medicaid work, we need to get to know our population, and we need to go engage with them in the ways that make most sense for that population. And I'll tell you what, it is not the same as for Medicare. And so that's exciting work because it gives us, more to do and more to think about. But it's important to know we should be differentiated a little bit in the especially in the engagement and case finding methodologies that we use.
Thanks so much for that. And I wish we had a bit more time, but maybe we'll need to have a part 2 conversation.
Let's do it again.
Thank you so much, Dr. Beltwell and Dr. Anguidanos, for sharing your insights. So to wrap up with the presentation, we spent some time during our conversation talking about shared care coordination platforms. So we're going to recap the role that technology plays in supporting some of the readmission strategies that we just discussed. So reducing readmissions really requires the ability for your care managers to stay engaged with your patients as they're moving between care settings and across the care continuum. So because of this, you really need an integrated care coordination strategy that's powered by data from across all of those care settings. And that data is then turned into insights and activated in workflows in meaningful ways, not just creating more noise. So the right provider or care team member has actionable insights at the right time so that they can make the best decision for that patient. Getting a bit more concrete here, to support care transitions, care managers need to be aware in real time of acute and post-acute encounters happening inside and outside of your health system. So for me, this is number one, like the number one thing to do. And it's also important to stay engaged during a patient's stay. Clinical data and things like readmission risk scores can provide your care managers with those early warning signs of patients that are at highest risk of readmission. Patients that are in a SNF, for example, and being aware that they might be in need of a hospital transfer soon. So you can catch that before they're already on their way or even in the ED. And then stepping back, focusing on readmissions, you also need to understand how is my network performing on readmissions? How are individual facilities that I work with driving readmission rates so that you can address problem areas proactively rather than waiting months for claims data to understand what's driving readmissions. So I'm proud to represent Point Click Care, an organization that does enable this level of integrated care coordination. So Point Click Care offers the leading senior health information platform comprised of the largest network of post-acute care providers, including 22,000 SNFs and long-term care facilities. So for those that are unaware, Collective Medical was actually acquired by Point Click Care at the end of 2020. And so we built upon that post-acute care network and added deep and broad data sets that include hospitals, ACOs, health plans, behavioral health, and other nodes of the care continuum. So Point Click Care and Collective coming together are sort of uniquely positioned with that post-acute care network and acute network, and other areas of the continuum to help organizations with care coordination through broad data, including real-time data and bidirectional data between the supports exchange between EHR to EHR, and also workflow integration. So at Point Click Care, through our daily interaction with customers, we're very familiar with the big impact that readmissions have on their patients and their business. And we've seen how incorporating the right tools, as Dr. Beltwell and Dr. Inguadanos discussed, can make such a positive difference. So a large network is essential for getting that visibility into where are my patients going, but it's also important that that network is active and engaged. And whichever care coordination platform you're using in your community, engagement and adoption is very important for care collaboration. And as an ACO, you need to be able to control the information that's available about your members and put it in front of the right stakeholders. So Dr. Inguadanos talked about this, the value that he's seen of a shared platform and connecting the acute world and the post-acute world with the outpatient world to provide more context. So a platform like Collective Medical that captures the attention of EDs and SNFs is very critical to that integrated care coordination strategy, and alerting them that, hey, there's more information about this member or this patient that might be helpful as you make your decisions. Also, to really make an impact on readmissions, it's important to get more insight into what's happening during a SNF stay and identify those patients who may need more attention, who have longer length of stay, lower functional status, or at high risk of readmissions. A lot of customers that we work with have relationships with SNFs and are reliant on the SNF to update them when something's wrong. But I think in an ideal world, care managers can be more empowered and know when they need to take action. So this can only be accomplished through data directly from the SNF's EHR, and not just ADT data, but also clinical data, such as medications and vitals and labs and radiology even. So through platforms like the Collective platform, care managers can view active medications directly on their screen, right at their fingertips, without needing to reach out to the SNF and know when to get involved. And that's possible because Point Click Care is the system of record in the SNF. So we really provide that broad view with real-time data. So now that we've walked through some of these takeaways, we'd like to just quickly hear from our audience again on our technology wrap-up, and whether are you interested in learning about how real-time data, bidirectional data, and insights can reduce your readmissions. We'll give just a few more seconds to reply to that. Okay, thank you so much for the feedback as you participated in the poll. I want to again thank Dr. Beltwell and Dr. Inguadanos for their time and for sharing their knowledge. I thought it was a great discussion. Brian, I'm going to hand it to you now to walk us through the Q&A.
Yeah, absolutely. It was a fantastic discussion. Thank you to all three of you. And we will now begin today's question and answer session. So as a reminder, please submit any questions you have by typing them into the Q&A box you see on your dashboard. And we'll get through as many as we can here as we approach the end of our time. The first question I'll throw out there, the attendee says, I agree technology is key, but this always seems to lead to more platforms and tools, which means more systems for care managers to log into. How do you overcome this?
Yeah, that's a great. Go ahead, Amy. Oh, go ahead, Nikki.
I'll just give a quick answer and then let you chime in. So I think that's a great question. And I think it's reality that providers and care managers don't want to go outside of their workflow. So interoperability and bidirectionality is key. So selecting vendor partners that are flexible and can either offer native integration or support data delivery through various methods is definitely something to look for.
Yeah, that's where I was going to go, Nikki. That really it's about how do we get to the patient in real time when they need it? How do we bring the medical care to them? And to the extent that we can use platforms that allow us to know in real time 24/7 when a crisis event occurs, if we can get pinged that a patient just entered an emergency department, we can capture them at that point in time for a dialogue. That's where we use technology to help us and to make our work more efficient. So we don't have to have a case manager necessarily sitting in the ED 24/7. It's much more efficient if we can use our tools, our resources to get notified when they're there. And at that point, we can come in and have that dialogue.
Yeah, I would just add, this is complicated work across, time and people and staff and shifts and patient populations and subpopulations, and we just need technology. And so it might seem messy that we, have a couple different tools for the job, but I am a fan of the right tool for the job.
Excellent. Thank you, all three of you, for weighing in on that question. We are at time, but I'm going to ask one more question before we sign off. So what are the best ways to identify high-risk patients to help reduce readmissions?
I'll jump in here. It is not the risk score in your electronic medical record that you haven't vetted yourself. You want to know your data. You want to know if you're in, rural America with a certain population. You don't want, to just take a predictive model generated from somewhere else and not look at the patient, as Enrique said several times. Look at the patient in front of you and look at your own data. So if there's one thing I've learned from helping thousands of teams, look at their own data analysis through the Aspire guide, it's that everybody has a general picture of readmissions, but then your unique hospital or setting or ACO or SNF will have some issues, signals in your data that you really want to know about. So know your data and target accordingly. And that's my advice to you.
I couldn't agree more, Amy. Know your community, know what's unique to your community, and then build to that.
Yeah. And I would just add, to round us out here, that I know that ACOs are using claims data. They're always going to use claims data to understand their population. Claims are the source of truth. That's not going away. But I think there's value in using real-time data to identify patients who have frequent utilization. So as soon as they hit the ED, is it their 5th visit? Is it the 1st visit, 2nd visit, 5th visit, 10th visit? Do they have are they newly diagnosed with a chronic condition? So using real-time data to surface those patients sooner rather than waiting months when maybe their utilization is no longer an issue.
Excellent. Well, thank you, all three of you, for an excellent discussion and conversation. Sincerely, Dr. Beltwell, Dr. Inguadanos, and Nikki, it's been excellent to be able to listen in and be a part of this. So I also want to thank Point Click Care for sponsoring today's webinar. Thank you to our attendees for joining today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thank you.